Hello everyone, it's me Dr. Ayaz Ahmed. I am working as an aesthetic dermatologist. Today I will discuss another important topic of dermatology. The name of topic is systemic therapy of psoriasis. Hopefully you will learn and subscribe my YouTube channel. The main treatment options of systemic therapy includes methotrexate, cyclosporin, acitretin, fumaric acid esters. Choice of systemic therapy usually depend upon age of patient, conception, presence of psoriatic arthritis or other comorbidities. Discussion of start of therapy usually depend upon patients and clinician. Methotrexate. It is a folate antagonistic that inhibits DNA synthesizing by dihydrofolate reductase inhibition. Given orally at a dose rising to a maximum of about 30 mg weekly. It is also given by a subcutaneous and intravenous injection, especially in rheumatoid arthritis and psoriatic arthritis. Give low dose of methotrexate to elderly people because of reduced renal excretion. It is metabolized in liver and significant anterior-hepatic circulation occur. It is used as a first-line systemic agent in plaque psoriasis with psoriatic arthritis. It is used in a localized severe psoriasis, generalized pustular psoriasis, and erythroderma. It has very low onset of action. Clearance rate is about 80% in moderate to severe psoriasis. Efficacy of methotrexate 15 mg is almost as equal to cyclosporin 3 mg per kg per day at week 16. PASI 75 was achieved at 16 week is about 35.5%. It achieved full efficacy in 6 months. Moreover, improvement can be noted from about 2 months. Side effects of methotrexate are nausea, bone marrow suppression, mucositis, hepatotoxicity, leading to liver injury in psoriatic patients, especially with diabetes, obesity, and alcohol. Use high dose of methotrexate in a psoriatic patient is recommended as compared to psoriasis. Serum amino terminal peptide of collagen 3 act as a biomarker for the fibrosis, has reduced the need of routine liver biopsy. Use of concomitant folic acid may reduce liver injury. Pulmonary fibrosis rarely been reported with methotrexate. This is in contrast with rheumatoid arthritis, in which it is noticed by the use of methotrexate. Guidelines suggest X-ray before start of methotrexate. Another systemic treatment therapy includes cyclosporin. It works by inhibition of interleukin 2 production by lymphocytes via calcineurin inhibition. Result in a reduction of TNF-KB and multiple cytokine including interleukin 2, tumor necrotic factor alpha and interleukin 8. Maximum effective dose is about 5 mg per kg per day. Moreover, range of dose is about 2.5 mg to 5 mg per kg per day. Flysteram reported greater efficacy of cyclosporin, achieved PASI 75 in 58% compared to methotrexate in a study of 84 patients. Side effects are renal impairment, hypertension, risk of malignancy. Side effects limits its use. It is used for maintenance treatment of psoriasis. Now acitretin. It is a metabolite of etretinate. It was first retinoid used in the treatment of psoriasis. It has narrow therapeutic window and long half-life. It binds to nuclear receptor of steroid superfamily, including vitamin D receptors, reduce keratinocytes proliferation and THB17 cells, and increase regulatory T cells. It is not immunosuppressant, but it is used in active malignancy. Dose is about 50 milligram or higher as required for the significant efficacy. Side effects are hyperlipidemia, hepatitis. It is teratogenic, so usually it is contraindicated in pregnancy. Women must avoid pregnancy at least for 3 years after its cessation. It acts synergetically with retinoid and PUVA. In combination, it achieves remission up to 94%. Now, fumaric acid esters. It's not licensed in UK. Moreover, it is effective for multiple sclerosis for which it is licensed. They cause reduction of glutathione with subsequent decrease Th1 cytokine production. It alters Langerhans cell function and reduction in tumor necrotic factor alpha Kb production. It is available commercially as a fumodone given 240 mg 3 times daily as a maximum dose. Side effects are GI upset, flushing, eosinophilia, lymphopenia, and one case of Kaposi sarcoma have also been described. Another systemic treatment therapy include apremilast. It is inhibitor of phosphodiesterase 4, which modulates pro-inflammatory mediator production. Drug is generally well tolerated and has completed 3 clinical trials for the treatment of psoriasis. It has recently received a license for the treatment of psoriasis and psoriatic arthritis. Tofacitinib. It is a genus kinase inhibitor, especially JAK1 and JAK3, currently licensed for the treatment of rheumatoid arthritis. It is in late stage of development for the treatment of psoriasis and psoriatic arthritis. PASI 75 was achieved in 40.8% in a patients taking 5 mg twice daily and 66.7% in a patient taking 15 mg twice daily compared with 2% in control arm. Now, Ponsimod. It is a modulator of sphingosine 1 phosphate receptor, or abbreviated as S1PR1 receptor. Antagonism of S1PR1 receptor prevents lymphocytes migration from secondary lymphoid tissue into the circulation. It is used to treat multiple sclerosis, but it is in clinical development for the treatment of psoriasis. PASI 75 at 16 weeks achieved is about 46% and 48% of a patient treated with 20 mg to 40 mg of Ponsimod respectively, given orally for daily. Side effects noted are heart block and liver abnormalities as compared to placebo. Thank you very much. Stay connected and subscribe my YouTube channel.